So here are my disclosures. Now, so what I'd like you to do is to look at this particular patient with a bone scan, and you can see a number of metastases. But I'd like you to look at that ring, the metastasis that's ringed on the bone scan. And some of you will say, where is it exactly? So yeah, so I put this arrow here, this ring here to show it to you. And there it is in the CT. So there's the MIP projection, that's the volumetric rendered image, that's the multiplanar image. And you can see clearly that this is a metastasis. Here it is on the diffusion imaging, on the water-only image from a whole body Dixon technique. But you don't see it very well on the T1 in phase. So the real question is, why do these different sequences not all equally show the metastasis? In this particular instance, we can focus down and say, why did the bone scan miss that lesion? And is this unusual? Now, it turns out, if you look very carefully using multiple modalities at metastatic disease, there are 7 different patterns of metastatic bone disease. So if you've never heard of this 7, this is the first time you'll hear it. You can basically divide metastatic bone lesions into low cellularity and high cellularity metastases. So some of you are going, what's a low cellularity metastasis? Yeah. How does that even work? And I'll show you, it does work. And there are 3 different patterns within low cellular metastasis. There's the osteoblastic mineralized metastasis, so that makes sense. You'd expect low cellularity. But you can get an osteolytic lesion that's full of fat. Osteolytic lesion full of fat. That's a bit strange. And I'll show you can. I also will try to show you an osteolytic lesion, which is a metastasis, has a sequestrum, but is actually full of fibrous tissue. Why does that happen? It does happen. And then there are the high cellularity metastases, and these are the metastases that you would normally be used to looking, the osteosclerotic, the mixed, the normal. It looks normal on a CT scan, and then the classical osteolytic lesion. So in fact, there are 7 different patterns. So the question is, why do you see these different patterns, and what explains what you see? And for that, unfortunately, you need to know a little bit of biology. You need to know what biology is being depicted by the multiple imaging modalities. And what you need to remember is that different modalities inspect the bone marrow in different ways. So for example, FDG PET. Now classically we think about FDG PET as a technology that looks at tumor cells within the bone marrow. Then you have to ask yourself the question, why are brown tumors hot in PET scans? Because they're osteoclastic tumors, correct? Why are they hot? Well, they're hot because macrophages and osteoclasts are also visualized by FDG PET. And then you'll see, so I've got an osteoclast here, I put FDG PET there. So remember that when we look at technologies and we assume stuff about what compartment it is that we're looking at, may not necessarily be true. Now, what we can say is that the CT scan looks at the trabeculae, but the CT scan also looks at the fat, because it's sensitive to fat. So different modalities are looking at different bone marrow compartments, and only by shedding light on the bone marrow with different technologies can you know what it is that you're looking at. The second thing that you need to fix in your brain is, how does a tumor cell interact with mesenchymal cells and normal hematopoietic cells within the bone marrow space, and how does that lead to osteosclerotic and osteolytic lesions? How does that happen in practice? So the most simple way to put it is this. At the top you have normal, no cancer. Then cancer comes in and it screws everything up. Right? But it screws things up in 3 ways. Okay? Now, mesenchymal stem cells differentiate into osteoblasts, and osteoblasts lead to osteosclerosis. So this is medical school stuff that you'll all remember, hopefully. Hematopoietic stem cells lead to osteoclasts. So osteoclasts are from hematopoietic stem cells. Osteoblasts are from mesenchymal cells. And this is a key piece of knowledge. And the hematopoietic stem cells lead to osteoclasts, and osteoclasts leads to osteolysis. And of course, we know there's a balance between osteoclasts and osteoblasts, and there are cytokines that control this. The first thing you may need to remember is that this thing here called OPG pushes the process towards osteosclerosis, and rank ligand pushes it towards osteolysis, which is why you use denosumab, which is an anti-osteoclastic agent, to push this process into that process when patients have lytic bone disease, and it's licensed for that use. That's why denosumab is licensed for benign tumors, like brown tumors, for example. Yeah, that's why it's licensed for osteolytic metastasis in breast cancer. It's licensed for that indication. And that's because it inhibits rank ligand. Okay. Then it gets a bit more complicated. So those are the basic facts. So what happens when tumor cells arrive? When tumor cells arrive, they hide within the bone marrow in a place called the hematopoietic stem cell niche. Doesn't matter. They hide in the bone marrow. Eventually they come out. When they come out, what do? It's like a hotel room. When you go to a hotel, if you are, I don't know, somebody famous, you call up and say, I want this bed, I want this pillow, I want this room, I want this view. Right? So the tumor cell does the same thing. What it says is, I need a bed, and the bed has to be made of woven bone. Right? So woven bone, it says, and the woven bone is made by osteoblasts. So here we are, tumor cells arrive, they signal, the osteoblasts lay down this woven bone, and then the tumor says, a bed to sleep for the night. Unfortunately, these soft bed also attacks groupies, right? If you're a famous pop star, groupies come along, and they all jump into your bed, right? You know this happens, right? Yeah. Okay. So this is hydroxyapatite. So, after a bit of sex, you're thinking, I need to get into bed, I need to sleep, right? But there's always groupies in the middle. So what you do is you go to the edge of the bed, and then you find you're against the wall of your hotel room, right? So what happens next? You think, well, I need more space. So you signal osteoclasts to make a hole through the wall so you can go into the next bed before the next round of groupies come in, right? Right? No, but this is what happens. This is what you have to remember. So essentially what we're saying is, this is what happens, right? So osteoblasts recruit, they make a bed, intratrabecular woven bone, tumor sits there, but you get all this calcium that comes in, and then you see this process here happens. You alter this OPG rank ligand ratio, you activate osteoclasts, you make a hole, you then go into the next bedroom, okay, and then eventually you go to the next bedroom and the next bedroom and the next bedroom, etc., etc. And eventually you get to the edge of the hotel, you go out of the hotel, and the whole thing collapses, right? So that's how it happens, right? So generally speaking, what you have to remember is this is how it happens, okay? So the primary action in breast and prostate cancer occurs this way. But for myeloma, it doesn't happen this way. For lung cancer, it doesn't happen this way. For renal carcinoma, it doesn't happen this way. In fact, for those tumors, it goes directly this way. The osteoclasts are the first ones to be signaled, because you don't need that bed, right? You don't need that soft pillow. Okay, so these osteoclasts are activated by a number of mechanisms. Bottom line, you get osteolytic lesions. Osteolytic lesions release growth factors into the environment, and then these growth factors result in more room, and then the tumor keeps continuing to grow. Now, if you just remember that conceptually, then you can understand what you see. So it's these interactions that result in these 7 different phenotypes. Let me just show you And so these are the phenotypes. Now, if you want to take a picture, you're going to take one picture, take this picture. But these are the 7 things that you need to remember. Okay, this picture will come up again. So some of those who miss it, it's the concluding slide also. Okay, so let's just have a look. Pattern number 1. I should have a name for this pattern number 1, but I don't have a name for it. Okay, so in this pattern, these are osteolytic metastases. The bone scan is negative. The MRI shows you low cellularity. Low cellularity. So how does that happen? Does it happen? Is the first question. Well, take a look at this. This patient has multiple myeloma. Look at the CT scans. There are so many holes, right? It's osteolytic. The MRI is negative. That's strange. There are holes, but the whole thing is full of fat. It's called the osteoporotic pattern of multiple myeloma. Why does that happen? Here's another patient. Here you see there are several lytic lesions. Some are full of fat and some are full of cells. So this lesion here is full of cells, but this lesion is an osteolytic lesion. It's full of fat. Osteolytic lesion, full of fat. Yeah. So both happen at the same time. Now, so the diagram gets a bit more complicated now. Okay, so simple diagram, a little bit more complicated, and then this. Okay. Now, we said that the mesenchymal stem cells make the osteoblasts. So the mesenchymal stem cell, here it is. It differentiates down this route here to make osteoblasts. Now, multiple myeloma, these purple cells here, make an enzyme called DKK1. DKK1. Now, the interesting thing about DKK1 is it inhibits this pathway, the osteoblastic pathway. That's why a multiple myeloma lesion never heals. How many of you guys have ever seen multiple myeloma lesion heal completely? Doesn't heal. There's no osteosclerotic margin. It never heals. Right? It's interesting, isn't it? And the reason is this pathway is completely blocked. It's a permanent, lifetime block. Even if you cure this patient, it's a lifetime block. So, in other words, this pathway here is regulated by something called Wnt. So this is the Wnt pathway. And this DKK1 is a powerful blocker here. But then the mesenchymal stem cells still say, I need to cure this, right? So they try and push down that pathway. And what happens is this DKK1 diverts mesenchymal stem cells into adipocytes. That's why they're full of fat. And fat is not passive in the bone marrow. Fat is not passive, it's active. So fat itself blocks the Wnt pathway. So this is a blocker. So even if you kill all of these cells, this block here is permanent because the fat cells will always be there. That's why bone marrow lesions never heal. Okay? The other thing that DKK1 does is it activates the signaling between osteoblasts and osteoclasts, leading to osteolytic lesions. So the summary is, pattern 1 is because the Wnt pathway is blocked. The DKK1 is pushing everything towards osteolysis, and you get fat deposition because the mesenchymal stem cells are differentiating into adipocytes, and the adipocytes are there forever and will continue to block the Wnt pathway even when the myeloma cells are gone. That's why that happens. Okay, pattern 1. Let's talk about pattern 3. Pattern 3 are osteolytic lesions, but the bone scan is negative. Strange. Osteolytic lesions, bone scans are negative. That means now you know that the osteoblasts are blocked. You should already know this. There's high cellularity within the soft tissues. Here's a typical example. This is a patient with breast cancer. Look at the DWI. They're stuffed full of cancer. I mean, it's liters of cancer here, right? Bone scan, negative. Look at the individual lytic lesions. All these osteolytic lesions. There is hardly any osteoblastic activity around this. That's why the bone scan is negative. Pattern 2. Okay. And here is the T1 that shows you all this bone marrow infiltration. Okay. Remember, when you do bone scans, and in this particular case, we're looking at a SPECT CT, what we're looking at, the technique is actually looking at osteoblastic activity. Osteoblastic activity. Okay? So that's why breast and prostate cancer tends to be hot on a CT, can be hot on a bone scan. Okay. Pattern 6. So you can see I'm not describing every pattern because otherwise you guys are going to glaze over. Pattern 6 is a really interesting pattern because it's a pattern in between and it's got something really interesting about it, and that's a ring sign. So if you look at a stir sequence or a T2-FAT-SAT sequence, you'll see these rings. Everybody has seen those rings, right? All of us have seen those rings. All of us say, this is edema. It's not edema. It never has been edema. It's a myth when people say this is edema, right? These rings are full of cells. Now, if you look at the center, that is mineralization. Remember there's groupies, settle in, that's them. The tumor cells are sitting on the margins. So that ring you see, here's a ring, lots of rings, here's another ring. These are tumor cells sitting on the margins of these lesions. How do I know that? Do a DWI. Do a diffusion scan and you'll see the ring. This is one of those lesions. Look. The center is the mineralization. Yeah, so there's the ring. Right, and there's you can see it's hypercellular. No, there. Yeah, and here it is blown up. You see, so there's the mineralization in the middle. So that corresponds to this dark area. This halo that you see around the margin, that is tumor cells. So that's a group is in the middle, and the tumor cells are being displaced, and you can see they're hypercellular on the diffusion sequences. The diffusion sequences show you this. Okay. Yeah. How do we know this? Well, we know histologically this is what happens. So this is a rat. This is a metastasis growing on a rat brain. Okay. And so there's the rat with its teeth in there. But if you look at the and this is the metastasis here that's growing on top. So here is the tumor here growing away. But if you look at the margin here, what you'll notice is that this is woven bone. Here's the cortical bone. Here are the tumor adenocarcinoma cells growing along here. And here are the osteoclasts. Can you see that? Eating away. Yeah. So that rim that you see between the woven bone and the cortical bone are tumor cells as they're eating away, signaling those osteoclasts. Make room for me, let's make some more room so that I can grow. Okay, so you can prove this histologically. So we're back to this picture, and this is the key picture. So if you want to take a second picture, this is the picture to take. Okay, so this is the woven bone with the mineralization. The tumor cells are at the margin. You've got the laminated bone, which is stopping everything growing. Okay. The signaling in the center with these osteoblasts are in the middle, so that's signaling over here. Tumor cells are being displaced to the margins. They are signaling osteoclasts through this pathway over here. The osteoclasts are activating, causing osteolytic lesions, delaminating the bone. That's causing growth factor release, and that's stimulating the metastasis to grow. And this is called the vicious cycle of metastatic disease. So you hear this term in the literature, the vicious cycle. This is the vicious cycle going on. So you osteolyze, you release growth factors re-stimulate, and you osteolyze again. And you go round and round. That's why these lesions get bigger and bigger and bigger. Okay. Now, if you follow a patient who doesn't respond over time, you can see this evolution occurring. So here is a sclerotic metastasis. And look at this little island over here. You can see that little thing over there? Difficult to see that little thing over there. But look what happens. The ring gets bigger, and bigger. Here is a little ring. You see, there's a little bit of calcification, a little ring developing around it. Look what happens. Gets bigger. And here's another ring developing. So this, you can think of this, sometimes the Americans call it the war zone, right? So this is where that activity is occurring. It's the margins. So you can see the war zone is getting bigger on the T2 fat sat and on the T1. And on the diffusion, you see the same thing. The cellular rim is getting bigger and bigger. So here is a metastasis. At the margin, you see this area of hypercellularity, which then grows and then becomes this ring with a bit of mineralization in the middle. Now, if you look at this very carefully, you will see this in your practice. This is just breast cancer. All of us have tons of breast cancer patients. You look carefully, you'll see it and understand what's happening. So I've said there are 7 patterns. I've shown you 3. Okay? But the biology is there. You should be able to sort out the others. And if you've taken that picture, it'll become very clear where these fall. Now I wanted to discuss multiparametric MRI with response to therapy. Okay. One of the things you need to remember is there are 2 mechanisms of cell kill that we, as radiologists, we only need to recognize. There's about 5 or 6 mechanisms of cell kill. But as radiologists, we need to think about 2. Okay? There is the shotgun approach, homicide. Right? So I go, bang, and loads of people die. Right? And then there is suicide, where we go, bang, only 1 dies. Okay? It's different in terms of its manifestation. So in the homicide mechanism, lots of people die, lots of cells die, as a result of which you get there's stromal breakdown, there's edema, and it looks different on diffusion and imaging and morphological imaging. So that patient is responding. All of you can see that. Yeah, the signal intensity has gone down. I'll show you the ADC in a minute, but you see how the T1 looks like it's getting worse. This patient is responding, but the T1 looks worse. And that's because of edema. Okay? And if you do an ADC map, so there's the ADC before treatment. It's about, the mean value is about 800. This is post-treatment, and the ADC value is 1427. Okay, so you can get an idea that this patient is responding, right? And we discussed yesterday how to make these sorts of images at the workshop if you were present. Okay, but bottom line for you, the ADC goes up as more water comes into tissue. Suicide is completely different. Suicide, you kill 1 cell at a time. You kill 1 here, 1 over there, 1 over there. And the thing about suicide is, if you commit and kill yourself, the first thing people do is nick something from your pocket, correct? Right? That happens, right? And that's exactly what happens when you kill a cell. If you kill 1 cell at a time, the neighboring cells take up these apoptotic bodies and use it as spare parts. Right? That's exactly what happens. So these apoptotic cells get eaten up and phagocytosed by normal cells, and so you do not get that stromal reaction. And you kill cells over here, you kill cells over there, but not everybody dies. And that affects the imaging appearances also. So here's a patient who is responding to therapy. Look at the T1, look at the T2, look at the diffusion, and all of you will say this patient is stable. Right? You're going to say this is stable. I'm going to say this patient is responding. Okay? And I know the patient is responding because if I do one of these histogram analyses, what I notice is that the ADC shifts. You can see the ADC collapses and it moves to the right, but it does not shift that far because there's no edema. There's less edema. You make space so the water molecules move more, right? There's a greater dispersion because there are spaces that are developing, so the range changes, right? The height is less, it's moved to the right, but not that much. This is response. But the interesting thing is you'll notice that it gets better over here, and over here, not over there. So it's exactly what I said. Some areas will die, some areas will not die. And that's what the histogram is representing. So this is an apoptotic mechanism, right? So that is tumor cell kill in a different way. The third pattern is something called sclerotic response. So essentially what we're saying in sclerotic response is that the war zone essentially ossifies. It essentially ossifies. So you have that sclerotic area, it just goes boom. It becomes very sharply marginated. And it's difficult to see on this, so I've magnified it up for you just so that you can have a look. You'll notice, if you look at these lesions, that lesion there, for example, becomes very sharply marginated, and you'll notice the emergence of fat within the lesion. See these lesions over here? See, and the lesions become sharper and sharper. And in fact, that is better shown on a CT scan, as you might imagine, right? So if you look at a CT scan, you can see that the emergence of new lesions on a CT shouldn't be called progression unless, right? Yeah, should not be called progression, particularly if the margins are sharp. Now, if you look over here, you'll notice the margins are sharp on this side, but not on this side. Can you see that? So this is, in fact, a partial response, not a complete response. Right? The only way, when you look at a metastasis and you see ossification, when you see increasing mineralization, look at the margin. It has to be edge to edge, an increase in Hounsfield unit above 850 before you call it inactive. Otherwise, it's very difficult to tell on a CT scan. Okay, but that's a sclerotic response, in other words, scarring, ossification of the war zone. Okay, so I've got 1 minute.
Just a
Couple of seconds. Okay, so this is what happens over time if you follow metastatic disease. And if you look over time, you'll notice the bone marrow comes back. Okay. So if you look over time, so it depends when you are imaging, right? You may only image at this point. This is edema, right? T1 edema. But then you can see that the patient's bone marrow comes back, and over time you'll begin to see changes. Okay, so that enables you to develop what's called a model of what the hell is going on. Okay, a model of what the hell is going on. So essentially what we're saying is, if you develop metastatic disease in your bone marrow, you replace the fat, increasing cellularity, signal intensity goes up. ADC, in fact, goes up a little bit and then starts to come down, but never goes above 14 to 1500. If you kill cells, you'll notice ADC goes up. Depending on the mechanism of cell kill, if you have very chemotherapy type cell kill, you get a very high ADC. Sometimes you get a low ADC. This is the apoptotic mechanism. Sometimes you just get sclerosis, in which case it just goes like that. You can develop this model, and when patients relapse, they just turn around and they go back round and round and round. I've got examples where they go round and round and round and then they die. But that is a model that you can develop in your brain to know where you are and in any particular area. So here's the final slide. You can take this picture again. I showed you pattern 1, I showed you pattern 3 and pattern 6, but there are other patterns. Okay, and if you look at these patterns and you see something that looks a bit strange, look back at this and think, what pattern was that? Okay, and if you want to hear the full lecture and you've got more time, go to my video on YouTube and you'll be able to listen to this whole thing again, but all the other patterns are also explained. Thank you very much.